Welcome, everyone. Thank you for joining us today. I am Robin Lerner. I'm the Director of Community Engagement here at Charles E. Smith Life Communities, and I'm so happy to be here with you all today. As many of you know, Charles E. Smith Life Communities delivers quality care and meaningful experiences personally tailored to those we serve, no matter where they are in life's journey. Our full suite of care and services available on campus include independent living, assisted living, memory care, post-acute care, long-term care, and primary care with a focus on older adults at Hirsch Health Center. If you'd like to learn more about our campus and all of the services that we offer, you can visit our website at smithlifecommunities.org. We'll be putting that in the chat, or you can call 301-228-0641 to schedule a tour. And again, we'll put that in the chat. You don't have to remember the phone number. Just a few things before we begin. First, as I mentioned when you all came on, please stay muted for the program. We want to make sure everyone can enjoy the presentation. Feel free to put your cameras on or off, whatever you prefer. I'd like to thank our sponsor, Optum. We appreciate your support for all of our programs. For those that need continuing education credit, those social workers, this will qualify for one Category 1 continuing education credit. If you will need continuing education credits, everyone will receive a post-event email. There will be a survey in there, an evaluation. We need you to complete that survey by November 22nd in order to get your certificates, and we will be emailing them out after that date. We'll also, as you know, we are recording the program today. The recording will be uploaded to our Charles E. Smith Life Communities YouTube channel, and it'll also be available on the resources tab of our website, smithlifecommunities.org. Again, we'll post that in the chat, and that information will be included in the post-event email that you will get later this afternoon or tomorrow morning. If you have questions during the presentation, please feel free to put them in the chat. We'll address questions following the presentation. Now, it is my pleasure to provide an introduction. Falls are preventable and do not need to be a part of the normal aging process. Today, we are so happy to welcome Leta Kant, the Clinical Manager for Select Rehabilitation. Leta will discuss how you can avoid experiencing a fall, allowing you to stay safe and independent. Leta, take it away. You're muted, Leta. You're muted.
Thank you for that introduction, Robin. I'm Leta Kant, and I'm a physical therapist by background. And if y'all are wondering, I do not have a northern accent. I'm from the South, close to Nashville, Tennessee. So just bear with me as we go through this. If you're like, what did she say? What was she meaning? That doesn't sound right. It's because I'm from the South. So I want to go through sharing my screen, and we'll get started here. And I hope all of you can see it in just a second. Okay, can everyone see my screen?
No.
Anybody? Pardon?
No.
No, we can't see it.
Okay.
So
let me go back.
Yeah, Leta, at the bottom, just hit share screen, and then you can just open up your PowerPoint. There you go.
Okay, everyone can see now,
yes.
Correct? All right, so we have a little catchy title called Falls Free Future. And I think it's important to think about how are we going to reduce the impact of falls? And why is it important for you as a social worker, a caregiver, for yourself, for any of the residents or patients or anyone you may serve? So we really want to talk openly a little bit about that. And I want y'all to think about some of the concepts that we're going to be presenting. Falls is a very complex topic. When we have a fall or we're trying to prevent falls, there's a lot that goes into that. So there's no way in this time I'm going to present all the different variables in reduction of a fall, but maybe give you some ideas of some things in your practice when you're working with families, individuals, or yourself that you'll be able to take forth and try to encourage and promote fall reduction. One of the things I would love for y'all to do is a takeaway is to be able to look at something that we present today and be able to implement it into your practice. And what I mean by that, maybe some educational tools, maybe some links, maybe just some conversations that you can have with individuals and people in your practice. So with that, I want to start to share more of the presentation. Falls can happen. I think this is really cute. You know, dogs fall down, bears fall down. Everybody can have an experience of a fall. And then what we want to think about as we talk today, what is our overall mission? We really want to, as providers, be able to reduce falls, identify when we're working with individuals, family, or ourselves, what are our risk factors? And then how are we going to look at those risk factors in order to reduce injury? And then ultimately, we want to be able to maintain our highest functional level for ourselves, for our family, and for those we serve. So some main concepts that you will get in today's presentation is some things of what you can do to reduce fall risk. Understand what the fall definition is, because different places you go, a lot of times they have a different description. This fall definition comes right out of the Medicare guidelines. Also, I want to talk to you a little bit about some things you might not have thought about, some muscles or strategies to reduce falls. And then looking at your living environment, a lot of you go in and out of different environments, talking to individuals in those environments, or you yourself knowing what can put you at a risk. And then some things I think that are very, very important. And I wanted to talk about what is meant by balance, and more balance. And so how does that balance and strength and flexibility really play in to reduction of falls? And then, are you at a risk for a fall right now? What is your next step? So as we, for some reason, I need to clear that. Right now, when we look at falls in the United States, it's pretty much a population of age 65 and older. But we're expecting in the next few years, by 2030, almost 1 in every 5 Americans will be over the age of 65. That is a major, major group. And the fastest growing is going to be 85 years or older. So what happens when we have a fall? Well, a couple of things happen. A lot of times when we have a fall, the majority of people that have falls never report it to anyone. So if you suspect somebody's falling because they're bruised, because they're starting to decrease their mobility or different things, a lot of times they fall, and I call them like our silent fallers. They don't tell anyone because of a lot of reasons. And some of those reasons can be is they don't want the attention focused on them. They're embarrassed. They feel like they should have known better how to do that. They really weren't hurt, so they don't see any reason to discuss the fall. So we have to think about that. Are we seeing these silent fallers? So 1 out of 5 falls cause a serious injury, such as a broken bone. And where do we see a lot of the bones broken? In our wrists and in our hips. The other significant injury is a head injury. And usually a head injury can be very significant in the sense that we could have a silent bleed in the brain and we just don't even know it's happening, and that could cause death. And more than 95% of hip fractures are caused by falling. Think about that. Think about 95% of all hip fractures in America. And falls are the leading cause of fatality and injuries in older adults. Why am I sort of passionate about falls, guys? As being a physical therapist for over 40 years, what have I treated predominantly in my practice in different settings has been related to falls, either orthopedic issues, head injuries, or just broken bones of any kind. falls are very, very predominant. So before we get into falls, let's ask ourselves a few questions. I want y'all to think about, is it inevitable that all older people will fall? Yes or no? And you can answer that in the chat. But let's think about that. As we age, we just sort of accept the fact that we're going to fall. Is that really a good thing to accept? So what happens with age? We know with age, certain things come up. We have decreased some strength, a lot of elasticity in our tissues could cause decrease some flexibility. We have some postural changes. We notice that people start leaning forward more. They may start swaying. They have overall decreased response times. They have maybe some other system issues like urinary incontinence, respiratory changes, vision, hearing. So we're not saying that with age things don't happen, but we are saying with age, do we have to fall? And so we look at falls as we're aging, or even in our life today, it's a challenging population. As we get older and we fall, we're at higher risk for serious injuries. It's got many challenging dilemmas. And we're going to talk about some of those dilemmas because we want to be proactive, not causing falls to happen. And you're going to understand what I mean by that. How do you think in your practice or in your everyday, are you causing a fall to happen? Let's discuss what you could be doing that could precipitate a fall. So when we look at falls and balance, they really go hand, and it's not an easy thing to think about. It affects everything in the medical field. When we look at it, it can affect your cognition, or cognition can precipitate a fall. You're having urinary incontinence, an orthopedic problem, and we will talk about that. Decreased range of motion in certain joints can precipitate falls. So all of these things have an effect on falls and balance. So some general risk factors that is associated with falls, and the AGS and the BGS just stand for American Geriatric Society and the British Geriatric Society. All of these factors we're going to be talking about in some form or another to be thinking about. Does the person you're working with have history or of falls? What is the medication? What is their mobility like? Their vision, their strength? Do they have any cardiac problems where they have very slow or rapid heartbeats? Do they have problems with footwear? I mean, you would not think about looking at individual shoes and what they're wearing as being a high risk issue. Their environment can play significant factors in their fall risk. So the real issue is, what can we do about reducing the probability of experiencing a fall? We want to look at answers to how to decrease your chances or people that you assist in reduction of falls. So what is the true definition of a fall? This may surprise you guys. The true definition is unintentional change in position coming to rest on the ground floor or onto a next lower surface. So the next lower surface is something that's been debated a long time in assisted living, in nursing homes and all of that. Well, they really didn't hit the floor, so why should we have to count that as a fall? Okay, well, they went into a fall. They changed surfaces from where they were. So maybe if someone hadn't been there to help them up, they would have went ahead and fall. They were out of control is how I like to think about it. The fall may be witnessed. You may find someone on the floor or the ground. No one witnessed it. But no matter where it occurs, at home, the hospital, whatever, falls do happen. And also to remember, falls are not a result of an overwhelming external force. Like we don't consider, like if somebody comes up and pushes you from behind and you fall, that's truly a fall from what you could have participated and prevented. That is a fall because someone pushed you. So when we talk about the phases of falls, I know y'all thinking, well, what in the world does she mean by phases of falls? Let's think about this. Initiating event, something happens to displace that a person's center of gravity or base of support. They get off balance. So, okay, any of us can have an initiating event at any time. What keeps us from falling? We all have initiating events. What happens is the second step, your system. What helps you, your protective reflexes, your responses, your balance, how you're able to regain stability once you're displaced in that environment to reduce that prevention of a fall. However, patients that fall, their systems didn't react appropriately. So then we go to the third phase, which is the phase we try so hard to prevent, is impact. And that's when you hit a lower surface than what you may or not been on. So what are the complications or the implications from a fall? Let's think about what happens. Now this I want y'all to really pay attention to, because what really comes first, the fall or the fear of falling? I put this slide in here because as you are dealing with patients or residents or families or your own family members, they start to develop, if they've had a fall, the fear of falling. So a lot of times it's hard to differentiate what's coming first. Where are they afraid of falling or are they going to fall? And sometimes I think about this as thinking about a slippery slope. Once you have the fear of falling, all other things sort of line up. You start having issues. You could have a fracture, pressure ulcers, decreased mobility, lacerations. So we're going to talk about that. Think about when working with people, the slippery slope. Where do you come in to help intervene in a slippery slope with an individual that has a falling history? If they have a fall, then they have a lot of times loss of confidence. They start restricting, we call it self-restricting, isolating themselves, not getting out as much, not moving around in their environment as much. They start what we call self-restricting. Then from that becomes immobility. And what I mean by that, once you start self-restricting, you start losing range of motion. You start losing strength. You start losing your core, your trunk, where your abdominal muscles are, where your back muscles are, what helps you center yourself when you're trying to walk and move. And then from immobility, often comes falls. And then with falls, we have what we will talk about today, not just trying to reduce falls, but the complications that come from falls. And we all know that when people start falling, then they break a bone. They may end up with more immobility in the bed, get a wound, get contractures, unable to move, and then end up with a lot of times pneumonia and complications that result in death. So always be thinking of this slippery slope. Where on this line can you help intervene and stop the slippery slope from happening to someone that you're helping? So when we look at falls, they usually come into two major categories. They're talking about, you'll hear people talk about intrinsic and extrinsic fall factors. And when we look at that, we want to do a little bit of a deeper dive into thinking about, is this an intrinsic event or an extrinsic event? And then depending on which it is, how am I going to approach that fall? So we look at intrinsics are not modifiable. Let's think about this. What does that mean? That means something you have no control over, something that you are not able to really do a lot with and modify in the first glance. I'm going to argue with you that there is a lot of things you might be able to modify. Yes, we have age-related changes. We talked about that. What happens as we all age? We have pathological conditions. A lot of times we can't help. Our patients have had cancer. They have osteoporosis. They have cardiopulmonary. They have multiple medical complications. Some of that we cannot modify. And then we have dealing with a lot of our individuals that we work with are on multitude of medications. Now, medications in themselves, we know help treat a lot of our medical complications. But medications also, if they're greater than 4 meds interacting with each other, they can be responsible for as much as 20% of the falls that we see nationwide. So medication is something that we think is not modifiable, but it's something we really might need to look at. On the extrinsic part, these are things we deal with every day that we think, oh, we can easily change. We can easily factor in to help reduce falls when we look at the physical environment, when we look at what the devices that a person may be ambulating with, when we check the footwear, what are they wearing? In the nursing homes, a lot of times I call them slippery socks because they have rubber or a little bit on the bottom, but if they've been through the washing machine a couple of times, that rubber is not there. So we have to look at a lot of people, the elderly like to wear those little warm socks. Can't blame them, but is that the most appropriate footwear to reduce a fall? And then we have different situational circumstances where people are like, let's just use an example, a hoarder. Well, they're putting their circumstances of all the clutter at a higher risk for falls. So there are some situational circumstances that you have to address. Now, when we look at the extrinsic factors, think about the home. Think about things in that environment, the furniture arranged, the carpet. Carpets can be very difficult. You can have very thick piled carpets, thin pile. You can have different kind of gray or brown colored carpet that may be very hard to differentiate the surface between carpet and maybe another flooring, lighting cords, temperature, clothing. These are all things that we have some responsibility or some control over sometimes to help reduce falls. So this is a picture of a little lady walking with her dog. And you might automatically think, oh my goodness, this dog, even though it's little, could be a big handicap, could really cause her to be at high risk for falls. I'm going to argue with you that maybe it's not. Maybe because she's up moving, she's moving her arms, she's weight shifting, she's looking, she's experiencing a lot of proprioception, visual input in her environment, that it's going to help keep her that much stronger. It's going to help promote more mobility. So sometimes we have to look at intrinsic and extrinsic and see, can we really change the following systems? If we identify a visual problem, can we work with that patient getting their vision checked? Can we work with that patient on maybe what's the appropriate tools that they need? If they're having hearing issues, if they're having a cognitive issue. Now, when we think about cognition, and we'll talk about this with falls, you have to think about where's that person? Are they mild cognitive impaired, moderate? Have they lost their ability of executive functioning? Being able to, you may say, you need to do blah, blah, blah to be safe. But if they don't have the executive function to follow you, they don't understand that. Their cognition is impaired. So then we have to look at other strategies to put in place to help that. So a lot of these things really fall in. Sometimes we look at intrinsic factors, but really with further deep dive, we can move them into extrinsic factors and have some control over reducing the falls. So in our physical environment, this is nothing new. All of y'all know this, that most falls do occur in the bedroom and bathroom. That tends to be our highest risk areas. Some in the dining area, especially if you're in assisted living or independent living. And then the other key factor I want you to think about, some of you on the phone are social workers. So this should be really at the top of your mind when you're looking at moving someone from one environment to another. That is when they are at extremely high risk for falls. Anytime we go to a new environment, we are automatically in a higher category for falls. And why is that? It's unfamiliar, that we're not sure where things are at. We don't have a good sense of what the layout of the land, so to speak, is. We haven't figured all of our issues out within that environment. So where do most falls happen? Within the first 24, 48 hours in a new environment. And then there is studies to show once they've been in that new environment, the next highest risk for a fall is usually around day 7 or 8. And why is that? That's because they think they've got overly confident and they start challenging themselves a little bit more, and that tends to increase their risk for falls. So I just threw this in here with medication, just so that y'all look at and understand when we take medication, a lot of things happen. We're at a risk for decreased mental awareness. We're at a risk for increased sedation, blurred vision, confusion, impaired balance. All of those things make you a higher risk for falls. And so age and place, we really want to make sure that of all the things that you may have some control over is looking at the vision with yourself and with your family members or the people you interact with. Now, we're getting into my territory of things I love to talk about as it relates to falls, and that's balance. A lot of times we don't think about, can we really continue to work on our balance as we age? We should be working on balance. As far as everybody knows, as we go through aging or keeping ourselves in shape, we all talk about, oh, it's good to be out walking. It's good to do strengthening exercises. It's good flexibility. But how much do we really zone in on the balance part of staying healthy? And balance is the ability to control the body's center of gravity over its base of support. So the trunk is where it all happens. In therapy school, we learned that you have to work on the trunk. And when I mean the trunk, I'm talking about from your pelvis to your shoulders. And the problem with that is, the issue with the trunk is that if you don't have a good, stable, strong trunk, then the extremities, the arms, the head, the legs, they're not going to function appropriately because they're coming off of that trunk, and that trunk has impaired issues. So we need to learn to make sure that we're working on our foundation, we're working on our trunk. So when you think about it, balance starts in the trunk. Balance, the center of gravity, somewhere around a little bit below or around your belly button, if you want to think about that. So why do we work on in balance? Because we have to look at what's happening in the posture, what's happening with the base of support. I always talk about base of support with patients because you have to really know where your limit's at. How much can you move laterally, forward, and backwards to affect that base of support? Some like diseases like diabetes, I put in here, what happens to their base of support? If they have neuropathy in their feet, they do not feel their toes, their foot, their first metatarsal head. They don't feel that. So now we have an issue with their base of support. And then we have to look at always strength and flexibility. And then the thing that you get into as we age a lot is our endurance, our ability of activity tolerance, our ability to be able to carry forth and keep our mobility. So one of the things I say, you as social workers and other healthcare providers and for yourself, look at your family members, look at your individuals you're working with, and watch for that cautious gait pattern. I think that's a first true tell sign sometimes that we are now getting into a high risk factor with falls. One, we already know that a lot of patients have the fear of falling. If you're identifying somebody that, or you yourself have a fear of falling, what are you going to do about that? The best thing to do is to get evaluated and get into an exercise program that's working on your balance, your strength, and your flexibility to help you be more confident and reduce that fear of falling. A lot of times when I'm working with patients, the fear of falling, what do I work on first? I work on them scooting forward in a chair and scooting back. I work on them leaning forward. If you ever get up from a chair, you notice that you really go forward. Your head goes forward over toward your knees. And when you are older and you've had issues with falling, you don't want to go forward. You want to go side to side or back or anything but forward. That's a scary place to be. So that's an issue that we all need to be aware of that could be happening. And then when you want to look at is somebody that's walking slower than they used to, they have decreased speed. They're saying in research now, if you ever look up gait speed, it can now determine the longevity of your life. They're saying it can really determine some issues with cognition. And what they do is take how fast you can walk within a certain time frame in a certain period. And from that, they calculate really how healthy you are. So speed of gait is very important. And if you notice a person that's no longer swinging their arms when they're walking, or they're not taking bigger steps, these are things we need to cue in on that we can start to help patients with to reduce their risk of falls. I included in here, but we will send out just some static balance exercises that you can do versus some dynamics. Standing with your feet together, standing with your feet shoulder width apart, standing with one foot in front of the other. The other thing I say that's really good is coming up and down on your toes. And this is good for us to do while we're brushing our teeth, or we're doing something where we're at the sink, where you can go up and down on your toes. And we'll talk about why is that important. Your ankles are very important, and your strength around your ankles to help reduce falls. So with brushing your teeth, I always like to say, as you brush, you go up and down on your feet, on your toes, and keep those dorsiflexors of your feet strong. So good news is, as we've gone through some of this, falls can be preventable. It is not because I'm 85 years old, I have to fall. No, there's strategies. There are things that we can do to prevent falls. So what are these strategies to reduce falls? This is a slide I put in that I want y'all to think about. At any age that you're at presently, you can start to help reduce the risk of falls in your life. One is, I've already talked about strengthening the trunk, strengthening your back extensors, your abdominal muscles, really making the trunk really strong. That's very important. Your triceps, everybody works on strengthening their biceps. That's that muscle that pops out in the upper part of your arm. That we always look at men and go, ooh, they got good biceps. That is not what really we're working on so much with falls. Biceps are important to pull, but what do you need to prevent falls when you're going from sit to stand? You need those pusher muscles, the push-up muscles, and those are the triceps. They're the ones on the back of the arm, and they're usually the ones that us as women and even men, we lose control and strength in those muscles first. So we really want to think about, are we working our triceps when we're doing our exercises? And then I always laugh about your hip extensors, your buttocks muscles. Your butt muscles are your strongest muscles, your gluteus maximus. They're some of the biggest, strongest muscles you have. And you really want to work on them. So when as you're going from sit to stand, or you're standing, you've got that strength, that balance in your core to help. And then thigh muscles, and then the other muscles that I think that get overlooked a lot, and we've talked about this, is your dorsiflex muscles, those muscles in your ankle that help bring your toes up, raise your toes up. What happens as we age, excuse me, as we age, we tend to decrease our challenges for our ankle strategies. And what I mean by that is we start walking on level surfaces. We no longer walk in the grass. We don't walk on gravel. We don't go up and down steps. We don't step over objects as much. So what we do every day right now in our everyday life keeps our dorsiflexor muscles strong. But as we age and we change our environment, it tends to decrease and those muscles get weak. So then we start to see, as we age, those short steps and shuffle gait. So some things to look at to reduce some of the risk factors. These are things you've all talked about and looked at before, I am sure of. You know, make sure you look at somebody's cognition. If they're having a lot of falls, you've got to ask yourself, is it cognitive related, or is it environmentally related, or is it they have a system issue? What is happening with that? You have to look at, and I can never, ever reiterate enough, the appropriate footwear. We have to get people out of slipper socks. We have to get people into more foot support. Furniture can be a very big thing if it's unstable. Also, they have the inadequate assistive device. Some people are using canes when they need to be on walkers. Vice versa, they may not have been adjusted appropriately for them, and this can cause a big risk factor. Poor lighting. Lighting is a very big component. And one of the things I think I have in here somewhere, distracted flooring, carpets, and tiles. It always amazes me that when we're working with people and they start falling, do we look at the flooring? What is happening? If they're having some cognitive problems, the flooring can be very distracted. They could be seeing spiders or bugs or other things if they have some cognitive or behavioral problems. Low-lying furniture, this is another thing, trying to get up off of couches, trying to get up of low toilets. These are things that can be modified to make it easier. Beds too high, chairs without arms. As we age, we need arms so that we can use our pusher muscles, our triceps to help us get up. And then from there, when we're halfway up, we kick in those buttocks muscles. So all these things are very important for us to look at in reducing falls. A few other interventions to ponder. Are you looking at customizing and helping have exercise programs with the people that you work with? Are you helping your family members have exercise programs? Are you looking at, do they have vitamin D supplement? That's been very, very much researched in the last few years, and most people are on that. Are we evaluating their physical environment? Are we looking at social isolation or self-restraining? What are the reasons they're doing that? And then a lot of patients, as we get older, or even younger patients, start to experience a lot of dizziness, lightheadedness. So then we have to look at that. What's causing that? Because it is treatable. And then if you don't get anything else out of what I'm talking about today, think about encouraging mobility. Mobility is so important. Now I'm going to give you an example of what happens a lot of times as people age. What do? We tell them to sit down, don't move, stay right there. I'll be right back. I mean, we put them in an immobile environment. Instead, we should encourage mobility. Let's get up and let's walk around. Let's see how you do walking to the door and back. Let's move, because movement means life. And you have to think about that. If we're not moving, we're decreasing our ability to live. So you have to encourage mobility within safe parameters. But we tend to think we're keeping people safe by immobilizing them, by telling them to sit down, not get up, when actually we're doing the opposite. We're encouraging immobility and often death. So ask yourselves, when you're talking to individuals, you're interviewing your family, you're interviewing the people you work with, talk to them about, when was the last time you fell or almost fell? Remember what the definition is. It's going from one surface to a lower surface. They may not hit the floor, but they've lost control. How do you feel about being on your feet? Do you feel unsteady? Have you lost confidence in moving, like walking on uneven surfaces, or when you try to bend over, do you get dizzy? Do you feel like you're going to fall and hit your head? How do you manage getting in and out of a truck, a car? Ask yourselves, what about sit to stand or standing to sitting? Always look at that, standing to sitting. Why? What happens is people start flopping in the chair as we get older. Why are they flopping in the chairs? It's because they're losing that strength of control in their thighs and their buttocks muscles and how to lower themselves slowly in a chair. And then ask, have you limited yourself because you're in pain? Is that an issue? And then talk to them about balance. Are you holding on to furniture to steady yourself? That's a good cue for you to say, okay, maybe we need to take a deeper look at what's going on. Tips for the home safety. All of you know these things, but I included it in here in case someone might need a quick review. Is to get rid of things you can trip over. We know about rugs. I have to constantly go over that with my parents. They have throw rugs out to yang, trying to get rid of these throw rugs. We now have grab bars inside their tubs and showers, which is what we need to do. Railings in and outside the house, if you need those. Lots of lighting. Looking at bringing things down to the lower level cabinets so people aren't reaching and stretching way over their head, which could throw them off balance. So those are some things to really look at. Mats in the shower. So encourage the following. You need to encourage wellness programs. We need to keep moving. Remember, mobility, mobility, mobility. The CDC has lots of information on falls program. We'll give you that information. Community falls and exercise program. Do they have a place that they can go and be interactive in a community? And then if you have gone through this and you're worried about, maybe they've got vestibular issues, maybe they've got urinary incontinence issues, maybe they've got some balance, some weakness, multi-cognitive problems, then you might want to consider referring to an outpatient therapy program so that they can get that help they need to help reduce the falls. And as being a PT, I'm going to tell you, as that is what we're trained to work on, PT, OT, and SLP, speech therapists, of how we can reduce the incidence of falls. So how can we help? As a PT, we can, or OT, or speech, we can look at vision, we can make accommodations for people that have low vision, balance, pain, having problems with activities of daily living. How can they still be mobile, but be safe using some compensatory strategies? We've already talked about flexibility and strength. Where you come in a lot in your practice could be the education, letting them know why it's important to continue walking, why it's important that you work on balance, why it's important that we look at cleaning up your physical environment, and what kind of modifications do they need in their home. So as a therapist, we will work on different exercise programs. We'll work on seating and positioning. Maybe you have some people in wheelchairs, and we tend to think that people in wheelchairs do not fall, when in reality, about 35% of falls happen either in wheelchair or sitting. So we need to think about that. And then we talked about cognitive issues. I just put this slide in. We're not going to go through it, but these are some things that you can observe for. You can look for loss of balance. You can look for shortness of breath with your individuals. Look at confusion. Look at if they're having difficulty going up and down stairs or curbs. You want to look at maybe they're having some anxiety over something. Are they still able to use the elevator, the escalator? You know, are they a simple task? Ask them to cross midline. Reach over for their left knee with their right hand with their left knee. Ask them to see if they can cross midline. Observation can be a really good defense against falls. So as a provider on this call, you're constantly going to be looking at what are the risks and what are the falls. You're having to constantly balance those risk factors with the falls. What I mean by that is looking at like medication. You have to balance. People can't just come off their medication, especially if they have significant cardiopulmonary problems, osteoporosis. There's different reasons they're on this medication. So we have to look at, what's the risk? How are we going to balance that? And then we have to look at, are we looking at in our programs and what we provide for individuals? Are we looking at a fall prevention program? Do we look at the intrinsic and extrinsic factors that precipitate a fall? Are we educating individuals about strength, control, balance, posture? And then are we reviewing with our nurses and our doctors the medication? A lot of times I ask, when was the last time you sat down with the doctor or nurse practitioner and you really looked at your medication and how it's interacting? And then are we keeping up to date on our vision, our hearing tests and assessments? Because we really know that these things, and cognition, we really know all this impacts falls. And then also looking at and constantly reviewing home safety. because a lot of times we go through a house and we think, oh, we've cleared the path. Everything should be good to go. And then you come back a couple of weeks later and they've added a rug or they've moved something around. So we have to constantly be looking at that. Now, I'm excited to tell you really about some new innovations that are helping us with falls, and they're called artificial intelligence equipment. And we've been using some of this in Heber homes in Rockville, Maryland. We've been using what we call Virtue Sense technology. And what is Virtue Sense? Virtue Sense is, and I have a whole slide on it, it's an accelerated artificial intelligence device. It helps us to predict and prevent falls with our patients, our residents. We use Virtue Sense in our outpatient therapy department. We use it a lot in just trying to evaluate where somebody might be at risk. And this is sort of a picture of it. It's on a screen and the patient is interactive with the computer screen. It can pick up how far they can walk without sway. It can talk about how much knee and hip flexion and how's their ankle dorsiflexion. It can really give us a good idea of where they are and how they are able to, well, let me back up. It helps give us an idea of where they rank with similar people of their age and what are the issues that they might need to work on. It also has a part of this machine. It identifies what particular exercise a patient may need. And then as we back, let me back up one more. We have another technology that's coming out called Mind VR. And what that is similar to putting like glasses on that have different scenarios and situations that the resident or patient can practice in. They can practice like they're live within a kitchen and how they're going to move around within that kitchen. And then OB is a technology that actually from a projector puts different images on a table or on a wall or on the floor where the patient or can interact with. Very good stuff. So we're starting to see a lot of technology come around to help us have more interaction in being able to determine when somebody's at risk for a fall and what kind of where they are in relationship to their age bracket and what we can put in place to help reduce that fall. So in review, guys, you always want to talk with the doctor, encourage the patients, encourage family members or yourself, talk to your doctor, evaluate your risk. Do you have any of these things that we talked about that you need to dig a little bit deeper? Look at your medication. What about vitamin D? Are you doing strength and balance exercises? A lot of times we're very good at doing strength, but we're not very good at balance activities. And then we've talked about eyes check, hearing check, get rid of things you can trip over, railing, grab bars, all these things you know. Now on the CDC website, they have some excellent material that you can use. I've just put up a couple of things that you can go that you can print out, have them mail it to you so you can give handouts. They have a guide to preventing falls in the community. And then some of the things that we have, contacts. We have an outpatient therapy department that's on the Heber Homes campus. You don't have to go through the campus. You can actually pull up to the door and go right into the outpatient therapy department. And these are the names of the individuals that can help you get that set up. And then I put the CDC link here. And then you'll also get a zip drive that's fall-free zip drive, future zip drive. And in this are 3 basic sort of exercises, the ones that had dynamic and static balance, talking about cognitive health, and then a checklist to reduce the incidence of falls. So this is just another slide that talks about some of the study resources for older adults that CDC website has. And then one of the things too that we work a lot on in therapy are chair-wise exercises. Working on is, remember I talked about the fear of falling, the fear of leaning forward. working on sit to stand a lot with individuals. And then I always like to say, what is your plan? What are you doing to protect yourself from a fall? What are the strategies that you're working on now? What are the strategies you're going to put in place for your family? And what are the strategies and tools that you can do and utilize to help others? And then I'm going to open it up for any questions.
Thank you, Leta. That was such a thorough presentation. I hope that you all learned as much as I did and got a lot out of that. We do have a couple questions in the chat, and if anyone else has any, please feel free to put them in there. One question is, can you give us your opinion about Tai Chi to improve balance?
Oh, I meant to mention that. Thank you.
Perfect.
Thank you. Tai Chi is excellent. I think a few things. I do Pilates. And I like Pilates because it has balance and flexibility, but it also takes off some of the concept of the Tai Chi. I think anything like that, Tai Chi, Pilates, yoga, all of those things are excellent to get into your everyday repertoire of trying to exercise. You know, we're all about, a lot of times we talk a lot about walking, which is wonderful. We talk about strengthening, but things like Tai Chi and yoga, they really come in to help a lot with that balance and keeping those muscles stretched out. Good question.
Great, thank you. Let me see. You answered the second question, which involved Pilates and yoga. Let me just see if there's anything else in here.
I may give you a little tip on Pilates and yoga.
Yeah.
I've done it a few, I've done it a lot in the last year. And then I took a break for a while. And then I'm now getting back in it again. And I don't know, at my age, I can tell a huge difference. I wish I had started more flexibility even younger than I am doing now. But I cannot stress to y'all how important that is for your own health, is to have some form of flexibility going.
Yeah. So Leta, you seem to talk about flexibility and strength training as two sort of complementary exercises.
Yes, I think most research shows that you need to have a strong strengthening program of 2 times to 3 times a week. You may be able to do that, but when we look at balance and flexibility with the geriatric population, research is showing they need to work on that every day. Mm-hmm. So strengthening, they don't necessarily have to work on every day, neither do we, but flexibility and balance is an everyday process.
Got it. Question here, what about for someone who has fallen and is in that very restrictive moving phase? What might be a good first way to start moving?
I think if they're already restricting themselves.
No.
Pardon? Okay, I'm getting some background.
Yep, sorry about that. I got it.
Okay, good. I think if they're already restricting themselves, you've got a couple of issues that have to be addressed. One, you have to really look at the psychosocial part. What is making them feel that they are no longer able to move? And then we have to look at how can we break down steps to promote mobility. Maybe we start with simple activities with them that promote mobility. And an example of this could be somebody's in a wheelchair or they're sitting. They no longer want to walk because they're afraid of falling. So then you might put them up to a table and you work on forward reaching activities, having them move things around on the top of a table, anything to get their upper extremities moving. Then you're going to work on maybe some diaphragmatic breathing, good exercises, work on their trunk, work on leaning forward and back, work on scooting side to side or forward, anything to get some part moving. I've started as low as people just turning their heads side to side in the bed because they were so weak and so deconditioned that we had to really just start very basic things. Everybody, I can't say everybody, but most of our people can get to some form of safe mobility. So we have to just start somewhere with them and have to break that task down.
Got it. And one other question here about what was it? I'm sorry, hang on one second. Standing squats.
Well,
Go ahead.
are they asking if they're good or bad?
From it's the person says from a chair I've heard are fantastic, but I worry if it's too hard on your knees.
Okay, that, that is something that you have to medically assess.
Sure.
Standing squats are good. Stand up and then squat down a little bit, back up. But doing deep squats as we age is usually not advisable. So what we do a lot of times as we age with older people is we have them work on scooting to the edge of the chair, using the arms of the chair, lean forward and stand up, and then work on different ways of holding it as they're going up, hold it as they're coming back down, as opposed to just doing a lot of squats. But, if you're younger and you have good health, and squats are done a lot for strengthening and for getting ready for sports activities. So that's my opinion. As you get older, you have to modify the task.
Got it. Makes sense. Great. Does anyone else have any questions? I think I've covered everything that was in the chat. As we mentioned, so you'll be getting a post-event email. It'll have a series of different resource material pages there. They'll all be in PDFs. You can just open them up and print them or save them, whatever you'd like. You'll get a survey for those that need continuing education credit. Please make sure that you fill that out before the 22nd. And just a few closing remarks. First, Leta, thank you so much for that presentation and for your time today. It was just so interesting and engaging, and I think everyone enjoyed that. In terms of our upcoming programs, calling all you coffee lovers, our final webinar for this year will be on December 14th. Grab your favorite cup of joe and join us virtually for an engaging and informative discussion on Wednesday, December 14th at noon. We will feature Cheryl Stillman, who is a writer, coach, and consultant, and she will be talking about the benefits of coffee. You might be surprised, some things that you might not even know about. So please feel free to look for that on our website. We also have a women's wellness event coming up on November 30th. That can be found on our website as well, smithlifecommunities.org. All that information will be in the post-event email, and we'll look forward to seeing you at that program and at our programs in 2023. We wish you all a happy Thanksgiving, and thank you for joining us. Bye.